All right, so look, I'm going to spend a few minutes talking about decompression illness. It's kind of the disease that we own as divers, so we're very interested in it. And look, to start out by just clearing up a little bit of confusing terminology, the term decompression illness is a collective term for two separate pathophysiologies that both involve bubble formation, but by different means. So bubbles can form from gas that divers absorb during a dive that's dissolved in their body. When those bubbles form, they form in the tissues or in the tissue capillaries and then appear in the venous blood. And the consequences of that we refer to as decompression sickness. And then pulmonary barotrauma, I'll explain in a moment, is fundamentally an overpressurization of the lungs, and it can introduce bubbles directly into the arterial blood, and we call that cerebral arterial or arterial gas embolism. But the C is cerebral, which is the consequence we fear the most. Decompression illness is not very common. It's an unusual thing. It's about 1 in 10,000 scuba air dives as a general ballpark. I won't dig into that any further. But bearing in mind that decompression illness is a collective term, the reality is that arterial gas embolism is much less common than decompression sickness. So a couple of series that we brought together in this paper in the New England Journal a couple of years ago, 3,000 cases, only 6% of them were due to pulmonary barotrauma and arterial gas embolism. So decompression sickness, bubbles forming from dissolved gas, is the most important of the pathophysiologies. I'll talk briefly about pulmonary barotrauma and cerebral arterial gas embolism. So this is a diagram from a paper we published in Lancet a few years ago, and essentially what it shows is that if you trap gas, compressed gas, in the lungs during a dive and ascend, the expanding gas can rupture alveoli, and bubbles from those alveoli can get into the circulation and go straight back to in the pulmonary veins to the left heart and be distributed around the body. The consequence we fear the most is cerebral arterial gas embolism. When that occurs, it's usually when there's been a rapid or panic ascent. The latency is very short. What we see is essentially similar to a stroke, but with bubbles. So multifocal cerebral symptoms like loss of consciousness and those other things you see listed there. The diagram reminds us, though, that if you rupture alveoli with expanding gas, there can be other consequences like bubbles getting into the mediastinum, spreading to the subcutaneous area under the base of the neck, so subcutaneous emphysema, and also a pneumothorax can occur. So that's pulmonary barotrauma, and I won't go any further with that. Much less common than decompression sickness. So decompression sickness, you'd be familiar with diagrams like this, many of you in the medical world, but basically what this shows is that when we go for a dive, in this case to 4 atmospheres or 30 meters, so the light blue line is the depth. We descend, the depth increases, then we stay at 30 meters. The pressure of nitrogen that we're breathing in the air increases, so the arterial pressure of nitrogen, that's the yellow line, that increases. And then gas gets washed into the tissues in the body. And depending on how much blood flow they get, tissues do this at different rates. But a tissue will accumulate nitrogen over the course of the dive, more slowly than the pressure increases, obviously. And then the same thing happens during decompression. So we come to the surface and, the depth decreases back to 0, the arterial pressure of nitrogen decreases, and the tissue unloads nitrogen. However, there's this period where the pressure of nitrogen in the tissue exceeds the ambient pressure, and we call that supersaturation, and that is the fundamental condition for bubbles to form from dissolved inert gas. So what happens when these bubbles form? Well, if they form in a tissue, they can cause mechanical tissue injury, they can provoke inflammation, and that's the sort of thing that causes musculoskeletal symptoms and possibly spinal cord symptoms. They can activate inflammation in the tissues and in the blood. So inflammation in the blood might involve systems like complement or kinins. That in itself can cause tissue injury. It can cause hemoconcentration and shock through loss of fluid through leaky capillaries. We see activation of platelets and coagulation cascades, which can cause flow reduction in the microcirculation. And those venous bubbles, which normally get trapped by the lungs, can arterialize across right to left shunts like patent foramen ovale, and then they can distribute in the arterial system. So these are tiny little bubbles. However, if they arrive in the capillary bed of a vulnerable tissue like the spinal cord or the inner ear that remains supersaturated after the dive, then gas diffuses into them and they can grow. And that has been associated with cerebral, inner ear, spinal, and skin symptoms in decompression sickness. So these are the symptoms. We have a group of symptoms we call the mild syndrome, so musculoskeletal pain, tingling, constitutional symptoms like fatigue and rash. At the other end of the scale, cardiopulmonary symptoms, which can be rapidly fatal if a huge number of bubbles arrive in the pulmonary circulation all at once. Bubbles can block lymphatic channels, causing swelling. Lots of little bubbles showering the cerebral circulation can cause cognitive changes, confusion, sometimes visual changes. If bubbles go to the inner ear, they can cause vertigo and deafness, and the spinal cord, classic spinal injury like sensory level and paralysis. And of course, any case can involve more than one of these things. So we see combinations. And in very severe cases, you may see hemoconcentration, shock, and coagulopathy. The truth is, most cases fall into that mild category, with the others being much less common. So how do we treat decompression sickness? Well, we can split that up into first aid and definitive treatment. So let me just speak about first aid briefly. And I'm using the collective term decompression illness here intentionally because there's actually no difference in the way we treat decompression sickness and arterial gas embolism. So any first aid protocol involves the ABCs, but I'm not going to dig into that for an audience of this nature. We recommend that divers who develop symptoms early after diving are positioned horizontally. They are administered 100% oxygen because that helps reduce bubble size, no matter whether they're bubbles of air from arterial gas embolism or bubbles of nitrogen and decompression sickness, oxygen will help. And fluids, either orally or intravenously, are helpful as well for improving tissue perfusion and gas washout. Now, we do point out to divers that 100% oxygen can only be administered in certain ways. So a demand regulator attached to a cylinder of oxygen, a bag valve mask system that the diver breathes through, an oronasal mask with enough flow to maintain 100% oxygen. A diving rebreather will allow 100% oxygen administration. A non-rebreather mask, not so much, maybe 70%, maybe a little bit more if they're used well. And a Hudson mask, obviously never, they don't get anywhere near 100% oxygen. The situation with fluids is that clearly if someone's got that fulminant form of decompression sickness, so hemoconcentration and shock, fluids can be life-saving. The role for fluids in less severe cases, perhaps not so clear, but most diving physicians would take the view that adequate hydration can only be good to improve tissue perfusion and gas washout. And so lots of us give fluids no matter what the severity we're dealing with. If we've got a case of decompression illness, we'll use fluids. We advise glucose-free crystalloid titrated to the clinical condition. So glucose-free because glucose isn't good for your neurological system. And oral fluids are fine, provided the diver is conscious and not deteriorating, but the truth is they're unlikely to benefit those who really need fluids, the shocked, very serious cases. When it comes to what you do with a diver in the field, this diagram is a summary of our current thinking, very simplified summary. So someone has decompression sickness or arterial gas embolism symptoms and signs. The first thing you do is lie them flat, administer high concentration oxygen, so 100% oxygen. If they are unstable or not fully conscious, then the process is to initiate evacuation to a hyperbaric facility as soon as possible. There's no debate about that. However, if they're fully conscious and hemodynamically stable, we put them in the horizontal position, perhaps add oral fluids to the 100% oxygen. And the next question is, do they have neurological impairment? If that's obviously the case, then again, there's no debate, they need to be evacuated. If they don't, then the next question is hyperbaric oxygen or recompression available within range of ground transport? So can you get to a recompression chamber easily? If the answer is yes, then you do so. If the answer is no, then we get into a somewhat more complicated consideration of options, which might include air transport to a hyperbaric facility, possibly not recompressing at all if the patient truly is mild. We might just treat with oxygen and fluids where they are, and sometimes appropriately qualified divers can use what we call in-water recompression. Now, in serious cases, we generally say rapid evacuation is better. There are some data suggesting that recompression within 3 to 6 hours is associated with better outcomes. But after about 6 hours, longer delays don't make too much difference. So if the modality you're choosing could get a serious case to a chamber within 6 hours, then that would influence your decision to choose that modality. So how do we definitively treat these patients? So recompression is the treatment of choice. So recompressing the diver inside a chamber, breathing 100% oxygen. So the pressure obviously reduces bubble size. Pressure and oxygen enhances the gradient for inert gas diffusion out of the bubbles into the blood and into the alveoli. So you resolve bubbles much more quickly. Pressure and oxygen enhances oxygenation of compromised tissue, and pressure and oxygen almost paradoxically has an anti-inflammatory effect. So this is the most common standard approach to recompression of a sick diver. It's called the United States Navy Table 6. It would be the most commonly used recompression table anywhere in the world. Starts with 3 oxygen breathing periods at 2.8 atmospheres, so equivalent to 18 meters of seawater, a decompression to 1.9 atmospheres, then 2 1-hour oxygen breathing periods separated by 15 minutes on air, and then a decompression to surface pressure. You can extend the table by up to 2 periods at each depth if the clinical progress isn't sufficient. In terms of drugs, this issue has been reviewed a number of times. Back in 2003, the UHMS, and then several articles since then. So there's not much you can do with drugs, with the exception of fluids in neurological or fulminant decompression sickness, low molecular weight heparin for prevention of DVT in paralyzed patients, like any paralyzed patient, and adjunctive non-steroidal anti-inflammatories, particularly in mild decompression sickness, then no drugs reach a strong level of recommendation. The typical approach is to recompress daily until there's complete resolution of symptoms or plateau in symptoms. So if they get better completely on the first treatment, no more recompressions. If they're not better, you keep going until they either are better or plateau over 2 consecutive days. There are multiple possible options. I've illustrated a couple of them there. They're all shorter than the table 6. There's no evidence for superiority of any particular approach, and sometimes the divers are just put in with routine hyperbaric patients undergoing treatment for other medical indications. In terms of return to diving, it's something that divers will always ask. We often say it's okay if they fully recover, if we don't think pulmonary barotrauma was involved. Now, if it was, or we think it might have been, then we'll sometimes do a high-resolution CT chest to see whether there are any predisposing lesions. And if there's not, then maybe the diver can return to diving. And also that there's no suggestion of a predisposition from the history. So, for example, that they get very serious decompression sickness after a relatively benign dive. And in that case, we might suspect one of these right to left shunts, like a PFO, and a bubble contrast echo to try and detect that might be advised. We often recommend a 1-month break, which is kind of arbitrary, but a 1-month break after a treated episode before they dive again. No diving until they're cleared at a review, and we counsel them about, diving approaches that might improve their safety. Now, look, any of this that's interesting to you, I've relatively recently published a very comprehensive review of decompression illness and all elements of its pathophysiology, symptomatology, treatment, prevention, etc. It's in DHM. It's free on PubMed Central, so you can download it from that link there. So look, thank you very much. That was a very rapid run through, and I hope I didn't go too fast, but we've pulled it off in just under 15 minutes. So.